I don't get excited about stuff like that. I'm sure you've realized that over the years. Things like that do not impact me. Okay, moving on. So I'm going to finish up urinary today, and I, I'll frame it this way. It's somewhat roundabout with the other group. I'm not going to go crazy with all of that stuff. Um, it's uh, I'll be very specific. I will try to get the review recordings out for the final this weekend if I can. It just depends on how much stuff I have to get done and all of that. But so I will try to get that done. But because what I'm going to talk to you today, this counter current multiplier system is pretty complex. And I'm not going to go into all of the physiology and the degree of detail. One, I would do in my advanced viz. Two, in general, and it's one of the hardest areas I think to understand. Kidney physiology, and particularly this aspect, is probably as hard as anyone that you would need to understand. So I mean, I really want you to be to not go crazy about this. I'll try to be very specific, is maybe the best way to say it, in what you will need to know for the final, because I mean, there's a lot of material involved for the final as it is. So I think I'll start here. This is kind of where I did 2 recordings. Whether you got a chance to listen to them or not, you will, I'm sure, or you should, I'm sure. And I got those done. I was supposed to go away, but I couldn't because my wife was under the weather. Thankfully, she's doing a whole lot better now. So that meant she kept me busy doing stuff yesterday afternoon, which is very annoying. Mushroom compost. Oh. It's all right. We're spending the summer in the garden and in the house, I think, doing so. Nevertheless, this is what I've covered this a couple of times. It doesn't hurt to cover it once more. This is a source of questions, too. All of this comes from something called the juxtaglomerular apparatus in your kidney. When it comes to blood pressure, we do auto control. It's only people who are, it's like every other system in your body. It's good news and bad news. It's great because we don't have to think about it. It's bad because it covers your blood pressure from what we call the mean. If you remember, go back and look up mean arterial pressure. From 80 to 180, you don't have to worry about it. Your kidneys basically can cover it for the vast majority of large differences in your average blood pressure. But if it's too high, and really the problem is high, not low. If it's consistently excessively high, it's causing damage gradually. And because of that, we don't realize it until it's too late. And all of a sudden, someone goes for a physical, or someone has a problem, or they start to have a headache, or their heart starts to pound, and they go for a thorough physical, and they find out they're in big trouble. It's just another one of those systems where big trouble abounds. So please I want you to be on top of that for this. So this is one of those systems that's like this. It's auto control. The juxtaglomerular apparatus has pressure sensors for fluid, and it has salt sensors. The pressure sensors particularly will release this. If they sense there's not enough push against them, low blood pressure, it will cause renin to be released. It's made by the kidney. The liver makes this precursor hormone called angiotensinogen. It's dissolved in the bloodstream. The O-gen means inactive. The renin activates it, and it forms what's called angiotensin 1. It has limited ability, but it will start early. Angiotensin, tensing angio means tensing blood vessels. It'll squeeze them a little tighter, so it'll start to raise your blood. The big deal is when it gets to the lungs, and it doesn't take long to get to the lungs. We're talking about seconds. For that angiotensin 1 to get to your lungs, where there's another enzyme there called angiotensin converting enzyme. The acronym we use is ACE. That converts it to angiotensin 2. That more efficiently tightens your blood vessels to raise your blood pressure. It tells your hypothalamus to make you thirsty. It tells your hypothalamus to release antidiuretic hormone. Okay? The antidiuretic hormone will basically pull water in from which is, if you look at those previous lectures, the distal convoluted tubules, and as important as all of these combined, it causes increased so it's four things, as you can see, four bullets here. Increased aldosterone secretion. It tells your adrenal glands on top of the kidney to make aldosterone. The aldosterone very simply acts in that same area, the distal convoluted tubule and the collecting duct, and inserts little openings that pull sodium and the water forms. So all of that is retaining it. So what it does is it pulls antidiuretic hormone, pulls water out of what we call the filtrate, the stuff that your kidney's processing, and it also pulls, additionally it pulls sodium to make sure we retain that. And without the aldosterone, our sodium would be, the potential for having significant loss of sodium certainly exists. So that's an important mechanism to remember. There's a little, I wanted to get to that graphic. So I remember, on average, depending on our size, between 160 and 180 is a good number. We pull out, we create that much filtrate a day. We reclaim 99% of it. That's the water. We liberate the better part of 2 pounds of sodium, 2 pounds of salt. We reclaim 99.5% of it. That's look at how much. So in liters, 2 liters is that. On average, we urinate between a half a liter if we're very dehydrated to 2.5 liters if we've had a lot to drink for whatever reason. And I'm not suggesting alcohol, I'm just saying a lot to drink for whatever reason, or overly thirsty for that day. And a rather scant amount of sodium, that's 3.2 grams, that's tiny. So it gives you an idea of how much work that they are doing that we really don't pay attention to. And these are the processes that go on. Reabsorption mostly occurs, as well as secretion, in the proximal convoluted tubule. I'll tell you the same thing I told the other group. On a licensure exam, they ask very generic questions. In the kidney, where does tubular reabsorption occur? Even though the correct answer is both proximal and distal, the correct answer for them, I'm sure, is proximal. That's nearly all the reabsorption occurs there. Nearly all, a large amount of the secretion, getting rid of stuff, occurs there too. But really, the secretion part occurs in the distal convoluted tubules. That's like the licensure exam based question, because they look in generalities rather than specifics. To be very honest, most of everything occurs here. The tubular reabsorption and tubular secretion in the proximal convoluted tubule. Your urine's basically processed. More or less 2/3 way processed, 80% processed, whatever, in the proximal convoluted tubules. Transport maximums. We talked about this when we talked about endocrine and diabetes. We have transporters that bring back glucose and amino acids and all these other guys that we need to keep a hold of. If we have more than that, if we have more of that in the filtrate, it's going to urinate out. That's what happens when a diabetic's out of control. The bad news, the longer they are at those maximums impact the transporters. It makes them less efficient. So the longer we're at transport maximum, the worse those transporters transport. And effectively, it increases spillage. That's why, so your transport maximum goes from 185 now down to 160. Or 150. So that's why it's so imperative, transport maximum, particularly for glucose, why it's so imperative to keep diabetics under very, very rigid control. That's the whole ball game in modern diabetes approach. Early aggressive sugar control, get the whole family involved. Diabetics are the worst cheats in the world. It's just the way it is. It's very difficult. I tell this anecdote all the time. My best friend's dad died of complications of diabetes. I remember going to the hospital with him. We were both just in our first years of college, seeing him having had one leg amputated, then more toes, and dying one. And then they told him, after his dad had died, a few years later, he moved to Florida. Because you're a pre-diabetic, you have to, because of this, we're going out to eat, and I said, oh, don't you want this? He said, I can't have it. I'm like, pre-diabetic. I said, don't you ever cheat? He looks at me and goes, I never cheat. Because I remember that day when we both looked in and saw his dad. Dad started to cry. Oh my God. Dad was a pro football player back in the 30s. It's just, I remember it like yesterday. Moving on. He doesn't. I do. That's my memory. So that's transport maximums. This is what I'm talking about. This is the proximal convoluted tubule. Most everything shakes there. In the we're gonna look at these today. These are the nephron loops. But what really happens here, as you get into the distal convoluted tubule, they made it much smaller. Yes, to be fair, there's pretty much only secretion, but comparatively speaking, most of the business happens here. This is the collecting duct, and there's multiple entry points. You probably got that in anatomy, I would hope. Nephrotic syndromes mean we don't know the cause. Do we see this in uncontrolled diabetics? Yes. Do we see this in certain kinds of infection? Yes. Does trauma play a role? Potentially. Autoimmune diseases? Sure. Something damages that filtration apparatus, and what happens is proteins start to leak out. Proteins help hold fluid in our bodies. These people get edema. They get fluid accumulation in their gut. They get fluid accumulation in their legs. It alters everything. The syndrome creates problem, okay, because your kidneys try to compensate, but in reality, they're just magnifying the problem without getting into the physiology. It's something, again, I would remember the name. I don't think I'm going to ask you anything about that, but that nephrotic syndrome is something you look for. That's a bad sign. That means those kidneys are about to fail. And typically, you have to, not only they're going to fail, but you have to address what's causing it, the underlying. A lot of times it's easy to see what's going wrong, but in order to get to correct it or improve it, you have to go to what's the underlying factor. Again, this is more physiology that I don't necessarily want to go into. What happens here is that we utilize sodium. That's why the aldosterone is so critical, to make sure we don't lose sodium. Sodium is sort of the driver. We spend energy to move sodium, and sodium creates currents through active transport to bring other stuff in, and it creates currents, backflow currents, to push other stuff out. So we co-transport and anti-transport. It's all about the sodium. It does this. So most of the energy when we're doing secretion and absorption comes from sodium. That's where most of the energy utilization is. And there's two types of nephrons. The cortical nephrons, 85% of these are the ones that involve this, basically reclaiming molecules and getting rid of molecules. They take care of the chemistry. You're going to see that the other 15% are called juxtamedullary nephrons. They're the ones that their long loops make up the pyramids, and they're all about concentrating the water. They don't utilize quite as much energy, and they utilize it a little bit differently. We'll get to that shortly. Saw that before. So they're just showing you different things and how they're pulling them out. And again, sodium is sort of the critical player, because it basically facilitates the movement of all these other guys that are there. So secretion is just the opposite, spitting it back out. Okay. So again, active transport mechanisms are part of it, but in the opposite direction. They're there. Oops. A lot of stuff, drugs, potassium, hydrogen ions, which means acidity. I mean, it's part in balancing pH. Typically, if sodium is moving in, potassium is moving out. Those are just general things to remember. Not going crazy about that. And a lot of the movement, particularly when we talked about that renin-angiotensin mechanism, is to maintain volume. The counter to that, if that's overly active for whatever reason, or we just have pulled in too much fluid, like I don't know why I'm so thirsty, I just keep drinking. What happens is that fluid will stretch the heart. It stretches the atria, and even to a certain extent, it stretches the ventricles. They release chemicals that counter the aldosterone. And basically, they insert channels and pull sodium back in to the urine. And again, water will follow the sodium. So they're called natrient, which means sodium, uretic, putting sodium in the urine. And so they are based, so they're to reduce the fluid. So this is homeostasis. So where are these pressure sensors? In the atrial walls and the ventricular walls, stretch receptors. And so without going crazy about that, this is the hard part. And I'm going to move over, and I will make sure you see this PowerPoint. I will load it up. It's 24B. I like the illustrations. Effectively, there are two mechanisms that allow us to, and we concentrate urine all the time. When you get up in the morning, your urine is concentrated. That's why first morning urine is used for pregnancy testing, because most of the water has been reclaimed, and the chemicals that are in there are easier to detect. That's why it will show up, very reliable indicator, the early pregnancy test. And it's not the only one. A lot of times, and we will get from patients, we want that first morning urine. Sometimes we have to get 24-hour urines in order to be able to assess things, because there isn't a whole lot in there. It's so diluted. What makes that possible is this thing called the countercurrent mechanism. It's about anatomy. That loop, that nephron loop, that long loop that creates the pyramids, that hairpin turn, even though they're not touching each other, the flow of particles and the different concentrations impact it. So that, you will see, creates an interesting mechanism that allows us to pull water out, and at the same time balancing it by pulling salt out. And then in order to maintain that, we have something called a countercurrent exchanger, because other than that, those pyramids will be filled with water or salt. We have to pull them back into the bloodstream. And that's when these blood vessels, the capillary bed, it's got a fancy name, it's called the vasa recta, for straight vessels that are draped over it. They have a hairpin turn too, and they work kind of the same way. This is not formed when you are born. Figure how long it takes to, quote, potty train a kid, a baby. Age 2 to 4, ballpark. Okay. My kids were probably in that range. Maybe my daughter was a little bit earlier. Maybe one of my sons was a little bit longer, on the longer end of that. That's all. Okay. What happens, that occurs because babies can't concentrate urine. It's just coming out. They get wet all the time. They change them all the time. As their body begins to be able to concentrate urine, it's not. And this is the mechanism. So it happens over time, and probably, I'm giving you a ballpark, 4 or arbitrarily 5, whatever. We're finally getting a handle on this thing. And so effectively what happens, and I'm going to switch to this other one, pardon me. Oops. Wrong button. Wrong button. Right button. So here it is. This is the countercurrent mechanism. So this is the way we're able to either put out fluid if we need to, or hold on to it if we don't. Opposite directions, hairpin turn. The multiplier, the exchanger, has to do with these long loops that are part of that nephron and the vessels that are draped to the capillary bed that's draped over them. The multiplier, okay, I beg your pardon, and the multiplier, where it actually is pulling out the water, this is just being able to sort of clear it, which I did it backwards, is ascending and descending limbs in the nephron loop. I have to show it to you. I'll show it to you now. It's like this. Okay, this is the loop. So here, this is the start of the glomerulus. This is part in the pyramid. This is the tip of the pyramid, the base, the tip of that pyramid where the urine is effectively dripping out. And what happens here's a proximal convolute, here's this long loop. And the key to this whole matter, how it occurs, is this. The descending limb has a thin wall, water can get out of it. The ascending limb has a relatively thick wall. Water can't move through it. This is permeable to water. These are important things to remember down the road. Descending limb, permeable to water because of it's a thin limb. The thick limb, water won't get through, but we actively transport the salt. That's where the energy gets used up. And this is what starts. It starts with the salt. The salt got pulled out, and to balance it out, water afterwards. And so what's interesting has happened over time. So when you're born, we don't have all these crazy numbers. By the time your kidney function matures, whatever that age is, on this limb side, what we call the urine, the filtrate flowing, and by the time it gets to here, it's pretty much urine, okay, has changed significantly to the point where this side is always less concentrated than that side, to the order of about 200 what are called milliosmoles. Your blood, your plasma, your tissue fluid, the norm for all of us, what we call isotonic, whether you're infusing an intravenous with normal saline or lactated ringers, the osmolality of that is about 300 milliosmoles. That's normal. But by the time all these changes take place over the X number of years it takes to mature, at the bottom of this is 4 times that. That has created this neat countercurrent because it's going in opposite directions with this hairpin turn. And so we continually, as we remove salt, we can continually create the demand to remove water. Maybe that's the best way to express it. I'll go backwards. A lot of slides. I just want to do the summary part of it. So these work together. They maintain this, what they call an osmotic gradient from normal right at effectively within the kidney and the cortex, right at the juncture with the medulla, to all the way at the bottom of the pyramid. So the multiplier creates it. That's what I was just pointing. The exchanger, because we'd have an accumulation of water and salts, preserves it. And so there you can see how it's there. That's the tip of the pyramid. And these are it's all with these long loops that are there. And so they have a lot of illustrations. You can see this a thin limb, so the water comes out. And you'll notice in another hairpin turn adjacent to it, what's happening here, this is the efferent arterial. This is the long nephron loop. And by the time it gets to the end of it, it goes from arterial blood to venous blood. And most of that energy is being utilized here in the thick limb because it takes energy to pull that sodium out. To sort of summarize it. So the countercurrent multiplier involves the loop, flowing in opposite directions, different permeabilities, active transport of solutes, read that as salt, out of the ascending limb. They're not in direct contact, but they're close enough to influence it. And they go over the same thing more and more. So without going crazy over all of this stuff, the difference is important. There's always a difference of about 200 milliosmoles between the two limbs. And that effectively, because of the way that it has been created over time, has created our ability to concentrate urine. Just the fact that the filtrate is flowing. Remember, we're 99.5% of the salt is pulled back. 99% of the water is pulled back in. That's an immense amount that goes on. So as long as this mechanism works, it's very easy. Why, most of us can, go to bed at night and wake up in the morning. We've got to go to the bathroom, but you slept for X amount of hours to be able to facilitate that. And they're just showing you through some images here. And again, it's the reason I'm kind of presenting this broadly rather than specifically. I didn't even present it that specifically with the advanced phys. is such a complex area that are there. What happens afterwards to make sure it's maintained, that gradient, is the exchanger. It utilizes here the vasa recta. They're permeable to both. It's also countercurrent, so it can exchange salt and water from that's accumulated in what they call the interstitial area and pull it back into the bloodstream. So it can keep doing it over and over again, or else you have an overload system. The blood inside the vasa recta, inside those capillaries, with the surrounding interstitial fluid. So by doing it in equal parts, it doesn't alter that osmolarity, so to speak, that's there. So the exchanger preventing rapid removal of salt and removing the reabsorbed water. So as a result, the volume of blood at the end is greater than the beginning. That's what happens. You're retaining, you're pulling in a sufficient amount of salt, but it's predominantly water would be the way to describe it. Because now you're restoring the blood volume, so to speak. And they just give you a bit more out of this. Again, once it's established, without the gradient, we wouldn't be able to get that concentration, so we couldn't concentrate urine. We'd be running to the bathroom continuously all the time. I think that's, and as you can see, if you look here, what's happening, I'll flip back just to show you. When urine comes out, this is hypotonic. It's more water proportionally than you have in your bloodstream. It's more water than you have typically inside the cell. So urine itself is hypotonic. So the norm is that, as a matter of fact, it's water and a sufficient amount of water to dissolve whatever is in there to be excreted. If it isn't sufficient, then you get things like kidney stones or granules, which can be a big problem. We're going to talk about that in a sec. So that's the summary of that. I'm going to go back to the other one to finish the talk up, so to speak. This one. So this is what they summarized here. The limbs being parallel. They didn't go into it. I didn't particularly care for that. As much as I think this was a very well done PowerPoint. I thought that this part was a little bit weaker. The difference between the multiplier and the exchanger, et cetera. They're talking about the same thing. They're showing water going out in the thin, salt going out in the thick, and I understand it. And then here you can see the capillaries that are draped over it. That's fine too. And I mean, you get a nice little summary, but that's about it. Different things that are really important to excrete. It's interestingly, a lot of the stuff like urea, which we're going to excrete the vast majority of it, is actually reabsorbed in the proximal convoluted tubule, so that it'll create a gradient, again, concentration difference, so we can push out more stuff at the other end in a distal convoluted tubule. We do this all the time. The very famous proton motive force, the way we generate ATP, we artificially create a gradient of protons to actually make the system work more efficiently. There are so many unique things physiologically about the body that help. It almost like preserving energy, because you're doing that. Now you're using concentration gradients to preserve having to use additional energy resources. Remember, about on average, 25 to 30% of your blood is going to your kidneys to do this. So it's to our benefit to minimize the energy expenditure if possible. So urea, from all the proteins we ingest, amino acid usage, it surely reflects proteins in the diet. 80% is reabsorbed, the rest is excreted in the urine. So, and that's a problem for people. That's why people with problem kidneys have to stay away from proteins. It's a problem. Uric acid, nucleic acid metabolism. Most people with uric acid that have gout, it's less about diet. It's more about a hereditary lack of a particular enzyme to help the uric acid to be processed. So it involves something different. Thankfully, just like high blood pressure, it's relatively easy to treat. There are a lot of good medicines with relatively limited side effects. It has to be identified. If not, it can be fatal. Oh, it's just the gout. Well, the reality, back in the day, people died from the gout because gout would make these deposits of crystals that would damage their heart, blood vessels, kidneys. And so they would, unfortunately, the gout could potentially, before we understood what it was. Okay. So that's part of it as well. So we excrete a certain amount of uric acid, we excrete a certain amount of urea, and we excrete a certain amount of creatinine. So all of those substances are how we can estimate what's called the glomerular filtration rate. That's the measure of how efficiently your kidney is working. Okay, and we do that from blood tests. And I've shown students that, maybe I showed you folks, I don't recall, with regard, whenever I get my blood test done, there's nothing, I have nothing to hide. And it'll estimate my what they call GFR. And as long as it's above a certain number, the doctor goes, oh, that's good. If it falls below, it's like, hey, we've got to talk about something's going on here. So urine composition reflects that. And it's all about homeostasis. So it depends on diet. It's mostly water. These are the metabolic wastes, those nitrogenous wastes. They're the big problems. And other stuff that's in there. As little as a half a liter, that's about a pint, as much as, 2.5 liters, we're getting close to a gallon, not quite. Okay, that's the normal output for most of us, whatever that is. And it plays a difference. I mean, if you're working outside, hot, you're exercising, you're different than if you're hydrating, however, whatever the occasion is. And there's just some of the chemicals that are in there. It's not a big deal. Glomerular filtration is determined by these renal clearance tests. There are ways to do it. Classically, we use these substances are neither filtered by the glomerulus, but they are filtered rather, but neither reabsorbed or secreted in the kidney. Creatinine and inulin. So normally they give inulin, which is a plant polysaccharide we don't really process. So whatever you give to somebody, it's going to go out. And you collect 24-hour urine because you have to measure it over a 24-hour period. That's the accurate way of doing it. And I've known plenty of people who've had to have this done, to collect urine for 24 hours. But again, common with diabetics and things like that. So they calculate that GFR. That's the only way we can really analyze whether they have, what the status is of their kidney disease. Do they have kidney disease, or are they going in that slippery slope toward having to be on dialysis? So there's lots of different things. There's glomerulonephritis, very progressive. We see this with any one of these types of things. There's so many things that can damage the kidney. And we're talking about diabetes. We're talking about infection. We're talking about different kinds of medication. We're talking about disorders in the blood, autoimmune diseases. All of these are in that category. And again, that's an acronym you don't want to see on someone with end-stage renal disease. So once they flow below, the normal, I think, is 125 milliliters per minute. When it gets below 60, that means your kidneys aren't working well. When it gets below 15 milliliters per minute, that means you're going to have to be on dialysis or have a kidney transplant. So as you can see, 3 times weekly or kidney transplant. None of these are good. Years ago, people had a lifespan of about, on dialysis, 5 to 8 years. It has improved dramatically with improvements in dialysis. Dramatically. That were there. I mean, they'd have to put a specialized loop. They used to take toughened bovine blood vessel because you have to keep sticking it 3 times a week. And those had a lifespan, and you had to replace them. Now I was told by a nephrologist, now we have ones that are here less than 20 years. Real advancements in the science behind this. So it's quite interesting, I think. So urine drips out of those papilla. This is an anatomy question. I probably have something. If I have one of these, I'll let you know when I do the recording. So, I mean, it's just that flow chart that's there that you've seen before, minor, major, renal pelvis. But this is getting to what, once the urine is formed and drips out, once it exits those renal papillae, and it gets into the calyces and eventually into ureters. Guess what? Nothing else happening. It's urine. Everything else is transport and storage. Problems there are significant. The ureters, about a foot long. Effectively, if you think of the renal pelvis as the top of the funnel, the stem are the ureters, one on each side. The big deal here is the epithelia. It's different. Transitional is an optical illusion. When there's no fluid, and same in the bladder. When there's fluid in the system, it squeezes these 7 to 12 layers of cells. It looks like just 2. When you empty your bladder, all of a sudden, and the ureters don't have any fluid in the bladder, you see the 7 or 12. You probably learned about this in AP1. Why it's often mistaken for like stratified squamous is when it's flattened out, but that's not the norm. When it's empty, you can see the cells are rounded on top with the nucleus. That's transitional epithelium. The trouble with this is we rely on peristalsis to move it along. And as you will see shortly, the ureter is very much like the esophagus. Just like a lot of structures, it's fan-folded. And that makes little nooks and crannies that are there. And particles get stuck. We have a name for those particles. Stones. And the nidus, the core, can be blood, can be bacteria, it can be calcium, and it can be other chemicals. And when they get stuck in there, peristaltic waves that can't proceed and are jammed in these areas create spasms. We have a name for those spasms, colic. Somebody in here babysat and mom said to you, oh, the baby's colicky. I had 2 colicky babies. Well, the colic is a name for the spasm that was going on in their alimentary canal for whatever reason, lactose intolerance, who knows. Okay, so this is called uretral, URETRAL, colic. Okay, so the obstruction, renal calculus means stone, and it obstructs those waves, hence renal, and the pain is intense. It used to be much more common in men, but we're seeing a fair amount in women. It's probably related mostly to calcium. If you take a calcium supplement, and the vast majority of them, calcium carbonate, formerly known as Oscal, for oyster shell calcium. If you eat a couple of tums a day, you'll see it's calcium carbonate. That's the calcium oxalate. Don't want to do that. I mean, our prior dog, we'll get to that in a second, had, because there's a lot of foods that have oxalates in them, and if you don't restrict them, he had like, the vet said, just tons, 20, 40 bladder stones that had to be removed surgically. Thankfully he did fine. That wasn't, wasn't why he didn't live past 12. That was more respiratory. But you can see this is what it looks like. If it gets jammed in these little areas, particularly when it's empty, then all of a sudden you get spasms, and they are extraordinarily painful. Seeing more of them in women. It used to be men, 30 to 50, extraordinarily painful. We didn't have as many ways to treat it as we're good. So here, uric acid, somebody with gout would have a tendency to form that. Oxalates, phosphate. Notice not carbonate, okay? As well as, again, blood, bacteria from infection, blood from some kind of damage. Collecting ducts are the renal pelvis, but jams in the ureters. They typically pass on their own rather than surgical removal. Again, just like gallstones, lithotripsy, high frequency sound waves. My cousin, who's a few years younger than I am, and I'm going to tell you, she was probably somewhere between 30 and 50, and they had to do the lithotripsy. So she's, it was probably 20 years ago. So again, there's a certain amount of inherited tendency that's part of that. I have no idea what would occasion that with her. A lot of times, vitamin D tends to make more calcium. I'm more of in the school that we're better to have more vitamin D than less, and that's become prevalent today. There's more and there's too much. Be aware of that. And another thing, urinary tract infections. The bladder is different. Okay, the big problem with the bladder is bladder infections. Okay, and The bladder is kind of like the stomach. When it's empty, those rugae, those ridges form. But there's a flat area called a trigone, and that's where the ureters come in and the urethra exits, sort of on the undersurface of the bottom of the bladder. It's flat, there's not a lot of motion. And when you get infections, that's an area because there's not a lot of activity. So effectively, that flattened floor is like a platform for infection to develop. And once again, it has transitional epithelia. I would be aware of that since the person who's talking to you had bladder cancer. Okay. Fortunately, and that's where it came from. Mine came because of an anatomical abnormality, aggravated by 40 years of 2 packs a day, which will F you up. Not that any of you would know that or will ever know that. Nobody here smoked for 40 years, 2 packs a day? I think not. Don't be stupid. And it's different. We're going to get to this in repro, which is we're going to start on Monday, as the distinction between the male and the female. I know you had this in anatomy, or you should have had an anatomy. There's a lot of differences. When we start, anatomically, we have this confluence of the urinary system, the reproductive system. So the anogenital area, all the openings are in close proximity. A lot of problems with infection. In the male, so we end up with women get bladder infections because it's a short trip. The urethra is, 2 inches long. In the male, we're dealing with a substantial amount. For it to get from here into the bladder takes a long time. So they get more problems with the urethra. It's anatomically based. And I delve in this in my micro class. That's where we're starting next week. So we'll cover more about the anatomy then. Here's that trigone, that flattened area. Here's the rugae. Okay. Transitional is here. I was fortunate again that my changes in the transitional did not go into the muscle. They stayed just on the edge of the underlying connective tissue, which was very fortunate for me. It's there, nothing else there. And we'll get into the urethra. It's really a conveyance. I don't deal too much with anything else from here. I'll talk about it more when we get there. You can see 4 centimeters, it's 1.5 inches. Okay, versus the male, 6, 7, 8. Depending anatomical differences notwithstanding. I'll cover a little bit about these 3 areas when I talk about it next week. In general, when we get to repro physiology is the male anatomy is more complicated. It's unlikely I'm doing a ton of that. Male physiology is relatively straightforward. Female anatomy is less complicated than the male. Female physiology is considerably more complicated. That's another difficult area. That's menstrual cycle and ovarian cycle. And we'll explore those. I don't do anything about urination. Yeah, there are all sorts of different problems that people could have that are there. The urine is a wonderful tool for analyzing health, certain diseases, diabetes particularly, different things will cause alterations in color. And unfortunately, these are age-related changes that occur. Loss of bladder control, less able to activate vitamin D, holds less urine, harder for kidneys to clear things, tubules thicken, lost a third of their mass by age 80, loss of surface area filtration decreases to about half by age 75. And I'm extraordinarily close to that number very soon. So I told the other class, I know many of your finals will be concluded with me, but finals end May 9th. The 10th is 74. 11th, so I'm not trying to grab for presents. It'd be nice. Won't impact your grade whatsoever. I can't be bribed. You can try. Feel welcome. I've gotten some very good grad gifts over the years. All right, goodbye. Have a great weekend. Maybe I can be bribed.